Hi, I'm Heidi DeBlock. I'm one of the hospitalists here, and I'm an intensivist also. And we're going to be reviewing ventilators and ventilator settings today as a little refresher for you all. First of all, we need to figure out what the ventilator does. We breathe in, we breathe out. We oxygenate and we ventilate. And so basically, that's all the ventilator does for us. Oxygenation is the exchange of oxygen. Ventilation is the exchange of carbon dioxide. And remember that carbon dioxide is an acid that will take you far in life. Things that affect oxygenation on the ventilator are our fraction of inspired oxygen, or FiO2, and PEEP, positive end expiratory pressure. PEEP is this. If this is my alveolus, I have a little bit of pressure coming in, maintaining pressure at the end of expiration into my alveolus, and keeps the alveolus open so that I have more surface area for oxygenation. What regulates my ventilation on a ventilator is the ins and outs of exchanging CO2. That is my respiratory rate and my tidal volume, how fast I'm breathing and how much I'm breathing. Mathematically, respiratory rate times tidal volume equals my minute ventilation, my minute volume. And if we take a look at this, these are our ventilator settings. I set an FiO2 and a PEEP, and I set a respiratory rate and a tidal volume. I tell the ventilator to oxygenate and to ventilate. Pretty simple. Fun part about this is it also changes and translates into my blood gas. If I remember that CO2 is an acid, the ventilatory part of my blood gas is my pH and my pCO2. And the portion of my blood gas that I am looking at for my oxygenation is going to be my PO2 and my O2 saturation. So if I get a blood gas back and the patient's having respiratory problems and my pH and my pCO2 are off, I know what to fix on my ventilator, my respiratory rate, my tidal volume. If I get a patient who's having problems with oxygenation, my PO2 or my O2 saturation are low, I know what I have to fix, my FiO2 and my PEEP. Pretty simple. And this also translates into the two common kinds of respiratory failure. I have hypoxic respiratory failure and I have ventilatory failure, hypercarbic failure. And then I just know exactly what I have to work on with my ventilator to make that patient better. There's one other thing that we need to know before we start looking at our modes of ventilation, and that is compliance. Compliance is a change in volume over a change in pressure. Why is this important? Because as we get sick, as we develop ARDS, pneumonia, CHF, any kind of pulmonary edema, our compliance will decrease. And it's also two different ways that we can ventilate our patients. Compliance being a change in volume over pressure is I can set a volume on my ventilator. Depending what my compliance is, it will take a certain amount of pressure to get me that volume. So I can say to the ventilator, Heidi wants 500 cc tidal volume. And the ventilator says, okay, Heidi, and it just pushes that volume into the patient. Or I can say, you know, ventilator, I want you to ramp up to a certain pressure, and depending on what my compliance is, I get a resultant volume. So I'm going to say, ventilator, ramp up to 25 centimeters of water pressure, and it's going to say, okay, and depending on what my compliance is, let's say I get my 500 cc's of tidal volume. So it's two ways of skinning the cat. I can set a volume, and depending on my compliance, the ventilator pushes in with so much pressure, or I can say, increase your pressure, and whatever my compliance is, I get a resultant volume. That's the difference between volume ventilation, pretty much, and pressure ventilation. Does that make sense?
Yep.
Excellent. We're done for the moment, and we will catch up with you on the modes of ventilation next.